Assalamu alaikum. First of all, I would like to thank MMIDSP for giving me this opportunity to speak with you. And the topic that I'm going to talk about is therapeutics in COVID-19 infection. These are my disclosures. This is on the slide. And the overview of my talk is that I'm going to talk about 6 things today in the next 20 minutes or so. We will have a short discussion about the targets for therapeutic interventions in SARS-CoV-2 infection. We will talk about steroids, whether they improve outcomes in patients with COVID-19. Who should get remdesivir and when? Is there a role for IL-6 or IL blockers? What is the role of convalescent plasma in treatment of COVID-19 patients? And does ivermectin have a role in the treatment of these patients? So to start off, let's look at some of the potential targets for treating or preventing SARS-CoV-2 infection or COVID-19 disease. Obviously, the most ideal target would be even before you get infected. So before exposure, if you would somehow stop the person being infected in the first place, you would prevent all the downstream complications of infection. The virus needs to get into cells, and you can block cellular entry. Once inside the cell, it needs to replicate and produce more viral particles. And if you can target that replication and stop that, that is another potential therapeutic target. And the virus needs to exit from the cell and go on to infect other cells in the human body. And that exit can also be blocked. And if you can find a drug that can do that, which could be a strong therapeutic agent. And most infections have some consequences on various organ systems of the body. And a lot of times these consequences are what cause significant mortality and morbidity from the disease and not the viral replication itself. So if you could somehow either control or reduce these consequences, you could improve outcomes in these patients. And vaccines, as I said, are probably the most important and most sought after intervention right now, and that is the topic of a separate talk that's happening today. We will talk about other therapeutic management agents, for example, antibiotic therapies, adjunctive therapies, immune-based therapies, and so forth. So let's start with immune-based therapies for SARS-CoV-2 infection. So these could be of 2 types. You could either deliver preformed immunity, or you could generate or modulate new immune response by giving therapeutic agents. The examples of preformed immunity include gut-brain products like convalescent plasma and IVIG, and immune modulators which generate or modulate new immune response include steroids, interleukin-1 and 6 inhibitors and blockers, kinase inhibitors, spike protein or receptor binding globulin antibodies, and so forth. So let's start with steroids, for which we have a fair amount of data now. Now, the use of steroids in infectious diseases and viral infections is not new. People have tried that in multiple infections before SARS-CoV-2 infection. People tried that in influenza, the original SARS infection, and MERS-CoV infection. And it turns out in all of those cases, there was no benefit that was seen with the use of steroids compared with either placebo or another agent that is a comparative agent. In fact, in some studies, some harm was also demonstrated. So steroids, in short, have no role in treatment of other infections, other viral infections, like influenza, and other coronavirus infections like SARS and MERS-CoV. For SARS-CoV-2, we have a fair amount of data that is accumulated now. And one of the largest trials is the recovery trial, which was an open-label controlled trial, which compared a range of possible interventions and treatments in patients who were hospitalized with COVID-19 disease. The trial randomized their patients to receive oral or intravenous dexamethasone for up to 10 days versus usual care alone. And the primary outcome was a 28-day mortality. So this is one of those trials which actually had a mortality endpoint. And in the end, there were about a little over 2,000 patients in the dexamethasone group and a little over 4,000 patients in the control arm, which received usual care. Now, if you look at overall mortality by subgroup, dexamethasone versus usual care, there was a significant improvement in mortality at day 28 in patients who received dexamethasone. And there was a 17% reduction in mortality at the end of that time period. Now, this difference was most marked in patients who were on invasive mechanical ventilation. All the patients who did not receive mechanical ventilation but received oxygen only also had some benefit. Those who did not receive oxygen at all or did not require oxygen at all did not have any benefit that was demonstrable in this group. So this is a summary of the trial in terms of percentage changes in various groups. So overall, there was about 3% reduction in absolute mortality in patients treated with dexamethasone. This was much more marked in those on invasive mechanical ventilation, but those who did not have any respiratory support or did not require any respiratory support, in other words, those who were very early in the infection or a very mild or asymptomatic disease did not have any benefit from steroids. There are some caveats to this trial. This was a randomized trial, however, it was open label, and results for several key endpoints are not really known. And study participants with COVID-19 who required oxygen but not mechanical ventilation had variable disease severity. So in other words, it's unclear whether all patients in this heterogeneous group derived benefit from dexamethasone, or whether benefit was restricted to those requiring higher levels of supplemental oxygen or oxygen delivered to a high flow device. There are other trials that have been published as well, and this is a meta-analysis of 7 such trials that have been published recently. And this is a summary of those 7 trials. So overall, there was a benefit that was seen in the dexamethasone group, or the steroids, if I should say, because this looked at other steroids as well. The benefit was more marked in patients on mechanical ventilation or those who were requiring oxygen. However, those who were in extremely critical condition, for example, those who were receiving vasopressors, did not have any significant benefit. And it turns out that dexamethasone had a significant benefit, which is in 3 of these 7 trials. Hydrocortisone also seemed to have somewhat of a similar benefit, but methylprednisone was not associated with any significant improvement in mortality. This is a different way of looking at the results for steroids by subgroups. So you can see that most subgroups do benefit. Those who received mechanical ventilation versus other types of invasive ventilation did benefit. However, those who were on vasopressors did not have any benefit. In other words, these patients were way too sick to achieve any benefit from corticosteroids. Moving on to IL-6 and IL-1 inhibitors. Tocilizumab is a prototype of this, and the fact that trial which was published very recently demonstrates the use of tocilizumab in patients with COVID-19 disease. So interleukin-6 receptor, tocilizumab is an IL-6 receptor monoclonal antibody. And they looked at that, the investigators did a placebo-controlled, randomized controlled trials of patients who were hospitalized with COVID pneumonia. However, the patients could not be in mechanical ventilation to enter the trial. And they were focusing on high-risk minority groups as the primary treatment target. The primary outcome was mechanical ventilation or death by day 28. And in the end, they had about 225 persons in the tocilizumab group who completed the trial and 115 in the placebo arm. And this slide shows you the results of the trial. So on your left are the proportion of people who ended up in mechanical ventilation or died or death alone. So there was a significant difference when you combine the two outcomes, mechanical ventilation or death. Tocilizumab had a significant advantage compared to placebo. But when you look at death alone, the numbers were not large enough to show a statistically significant difference. There was a time difference to hospital discharge between the two groups or clinical improvement. So there was about a 1.5 day shorter time to hospital discharge in patients who received tocilizumab versus placebo, and time to clinical improvement was about 1 day shorter in the tocilizumab group. Again, this is similar data, the same data shown in a different format in the Kaplan-Meier curve, which shows that there was a significant improvement in patients who received tocilizumab. I've tried to summarize a bunch of TOCI trials which have been published to date. And other than the 2 trials I showed you in the previous slides, the results are kind of mixed. But when you look at, when you combine all these studies, which is the extreme right bars on your screen, there were about 2,202 patients enrolled in all these studies combined. There was a slight benefit, about a 4% absolute benefit in terms of overall mortality in patients who received tocilizumab versus whatever control was used. The other drug in this group is anakinra, which is a very common IL-1 receptor antagonist. And for some reason, this drug has not really made it to the mainstream. 2 small trials have been reported, which have shown that patients who have severe bilateral COVID pneumonia have a mortality benefit in patients who receive this IL-1 receptor antagonist. Moving on to remdesivir, which is probably one of the most used and one of the most studied drugs. One of the first large randomized trials was the ACTT1 study, and this looked at remdesivir 200 milligram loading dose followed by 100 milligrams once a day for 10 days versus placebo. And they enrolled 1,000 plus patients in the 2 groups. And inclusion criteria including the patients needed to be hospitalized and they must have confirmed SARS-CoV-2 infection by PCR. And they should have pneumonia confirmed by imaging or clinical assessment and oxygen saturation of 94% or less of bone air. Patients could be on supplemental oxygen or could be on mechanical ventilation. And their primary outcome was time to recovery from day 1 through day 28 after receiving remdesivir. So on your left-hand side of the slide, you see the median time to recovery, which was significantly shorter in patients who received remdesivir 10 days versus 15 days. And the rate ratio was 1.29 with a significant p-value. However, mortality, although numerically different, was not statistically significant in the 2 groups. So in other words, in this group of patients, remdesivir was associated with the shorter time to recovery, but not mortality benefit. Remdesivir is also tried with kinase inhibitors. Briefly, kinase inhibitors are agents which inhibit cytoplasmic tyrosine kinases. They modulate or blunt inflammation in patients with certain diseases. And the ACTT2 trial is the one that looked at the combination of the 2 drugs. Looked at remdesivir with or without baricitinib. So the case arm was remdesivir given for a 10-day course plus baricitinib, and the placebo arm got remdesivir alone with placebo and no baricitinib. Again, the primary outcome was time to recovery at the end of 28 days. This trial also enrolled a little over 1,000 patients. 14% of the patients were not on any supplemental oxygen, while a little over half were receiving supplemental oxygen. 1/5 of them were receiving high flow oxygen or non-invasive ventilation, and 11%, or 1 in 10 patients, were intubated on mechanical ventilation or on ECMO. And the results are shown on this slide. The median time to recovery was slightly shorter in the baricitinib group by 7 days versus 8 days in the placebo plus remdesivir group, and this was statistically significant. There was no significant difference in terms of, let me rephrase that. There was a slight decreased mortality that was observed in patients with baricitinib group, and this was statistically significant as well. And patients who progressed on to receiving higher level of care or invasive ventilation was also reduced in patients who were receiving the combination of baricitinib and remdesivir. So in summary, median time to recovery was shortened by 1 day. Clinical status was improved. But there was a benefit in composite death and progression endpoint observed in the group as well. Moving on to convalescent plasma now. This was a retrospective study based on a US national registry, which looked at convalescent plasma antibody levels and mortality related to COVID-19. They looked at a little over 3,000 patients, and what they found was that in patients who were not receiving mechanical ventilation, giving plasma with high antibody levels was associated with a low risk of death. So patients who received convalescent plasma, which contained high levels of antibody, had 22.3% mortality versus 29.6% mortality in those who received convalescent plasma with low antibody levels. This is another way of presenting the same data in a little more detail. So among more than 3,000 hospital patients, recipients of high titer convalescent plasma had a lower mortality overall. And the effect was greatest in patients who were not on mechanical ventilation. In other words, patients who had less severe disease tended to have a better benefit in mortality with receiving convalescent plasma. This is another study, but this time this is a double-blind randomized controlled trial of about 160 patients. And this shows that early administration of high titer convalescent plasma in patients with mild illness reduced the progression of COVID-19 disease. So the summary of the two trials is that, or two studies is that convalescent plasma is beneficial, but it has to be given quite early on. And the benefit is lost if the patients are well progressed in their disease. Finally, let's talk about ivermectin. There has been a fair amount of interest in this disease based on anecdotal reports. And fortunately now a randomized clinical trial has been published. And this shows that among adults who have COVID-19 disease, ivermectin compared to placebo is not associated with an improvement in time to resolution of symptoms. And there is no difference in mortality in the two groups. So the short answer to the question about ivermectin is that the findings of this well-done clinical trial do not support the use of ivermectin for treatment of mild COVID-19 at this point in time. So how do you combine all these drugs together? When to give which drug or so? So I think the important thing to do is figure out the disease severity in COVID-19, because that would determine what treatment would be helpful in those group of subgroups of patients. If the patient is not hospitalized and has mild or moderate COVID-19 disease, perhaps neutralizing antibodies or convalescent plasma would be of use. In this group, if they're not receiving oxygen, dexamethasone should not be used because this has not been shown to have any mortality benefit or any other benefit. Patients who are hospitalized but not requiring supplemental oxygen would likely benefit from convalescent plasma. And again, dexamethasone should not be used because they're not on supplemental oxygen. However, when you move along the severity spectrum to hospitalized patients requiring oxygen, supplemental oxygen, remdesivir, dexamethasone with or without remdesivir, and baricitinib plus remdesivir would all have a possible role in improving clinical outcome. If patients are receiving high flow oxygen, then dexamethasone with or without remdesivir and tocilizumab both may have a role in improving outcomes. Hospitalized patients who require invasive mechanical ventilation, intubated patients, or those who are on ECMO, require critical care measures like good ventilatory support and other supportive measures to have better outcome. Again, dexamethasone and tocilizumab are likely to have some benefits in this group of patients as well. So when you look at it another way, we're looking at which drug to use when. So dexamethasone has a benefit in patients who are receiving invasive mechanical ventilation or high flow oxygen, but no benefit in mild disease and those not requiring supplemental oxygen. Tocilizumab with or without Dexa is helpful in patients who are admitted to the ICU within 24 hours of ICU admission, those who are in invasive mechanical ventilation or high flow oxygen. And a specific subgroup of patients who has what we call the cytokine release syndrome, which means meeting of 3 of the following 4 criteria. CRP level of 10 times the upper limit of normal, ferritin of more than 1,000, or a high P-dimer level should be candidates of tocilizumab. Baricitinib is for hospitalized patients with steroid therapy used, and it must be given remdesivir based on the trials that is shown. So I'll stop here, and I'll be happy to take any questions that you have. Once again, I would like to thank the MMIDSP for allowing me to speak today. Thank you.